If a kid is proven to be allergic to a penicillin, that's amoxicillin, penicillin, that family, does not mean you're allergic to cephalosporins. Mm-hmm. I was trained as a pharmacist. They said it was a 8% crossover, but recent studies say that may not be true.
Far less than that.
Maybe a 2 or 3%. So if you have a kid that has a strep throat, mm-hmm. it's probably wise to use a first, maybe a second generation cephalosporin. Now, what's about the other way? Whatever the reason, the kid was on a second, third generation cephalosporin and gets what they appear to be an allergic reaction. It's perfectly okay to use penicillin, isn't it?
Well, with caution. I mean, we face this situation in the hospital all the time, where they come in firstly, they come in labeled penicillin allergic, but they actually tolerate an IV ceftriaxone, for example, commonly used just fine. Well, that to me is a way to undiagnose that penicillin allergy. But on the other hand, if you have a true urticarial reaction to a cephalosporin, that requires an allergy immunology consult, because then you may be allergic to the whole category of beta lactams.
Private practice, we get away with it a lot. But a true allergic reaction to the antibiotic, it's not a little rash. It's a symmetrical rash. Mm-hmm. You like to see some hives, right. Some swelling, lips, fingers. Is that correct?
Yes. And then in that situation, why you get away with it sometimes is it may be the vehicle. It may be the other ingredients in the suspension.
Could be a flavor.
Right. And it's not necessarily the cephalosporin, the active.
So there's ways of a good allergist to determine, not 100%, right. Determine this is really a problem, not a problem.
And empirically too, it's acceptable to try a related drug as long as you can observe the child in the office and as long as you know the family will get back to you, if indeed within a day there is a reaction, because then you can confirm or refute that diagnosis of an allergic reaction.